All right, now I have the pleasure of presenting Dr. Adam Holtzman. Dr. Holtzman is an assistant professor in the Department of Radiation Oncology at the University of Florida, practicing at the UF Health Proton Institute in Jacksonville, Florida. He specializes in proton therapy for skull-based and central nervous system malignancies. Dr. Holtzman has received multiple awards in recognition for his dedication to clinical care, compassion, and research. And just something is fun to know that he is a quadruple gator. He received his undergraduate degree, medical degree, and did his residency training at the University of Florida. Now he's employed there. Yet he was born in Texas, so wasn't a gator from birth, but a quadruple gator is pretty good.
Pretty close, pretty.
So Dr. Holtzman, I am now turning the time over to you.
Thank you. So welcome everybody, and thank you for your time today. We know that with all the Zoom meetings, there's a lot of competition for your attention, and we appreciate you spending some time with us to learn more about what we have to offer with proton therapy. So with that, we'll get started. So today's discussion, dose-escalated proton radiotherapy for sarcomas. The first thing I'm going to do is we're going to launch a poll, and I just want to see if this is working and we have everybody interacting and we have the computer system figured out. So you should see a poll currently, and it is, what is the definition of a proton is the first question. Let's see.
Is everybody seeing it up? I'm not seeing it up here.
Hold on, we relaunched that.
Oh,
so
there we go. Okay.
A lot of smart people. All right, we'll keep it up for 2 more seconds. Okay, we'll keep it there. So it looks like 100% of people got this correctly. I was hoping there'd be at least maybe one person that would answer a positive person, but you're all correct. And thanks for making sure that the polling system worked. So the outline today, we'll first talk about sarcomas and radioresistance, the reason for dose escalation, an introduction to proton radiation therapy, and some common management discussion items that come up in the treatment of patients. So obviously disclosures, I work for the UF Health Proton Institute. I conduct research outcome studies within these areas, although I have no financial industry relationships relevant for the present, for this present talk. Just to set the audience, so you have an idea, this is a very broad group. It's multidisciplinary, from oncologists, pre-medical students, those with a lot of background in proton radiation therapy, and some who are just being exposed to this type of treatment modality. So if you are an expert in proton radiation therapy, hopefully I can address some of the sophisticated issues that we discuss, but just understand that some of it may be more for a broader multidisciplinary audience. And we'll talk a little bit about where protons and proton selection for patients and why this might be a useful resource for certain patients. So it will not be all-inclusive. So we have a large multidisciplinary group here today. So you will not walk out being an expert in dose-escalated proton radiation therapy, but Christina can provide our emails and contact information. If there's any questions, don't hesitate to contact us at any time. This is not meant to be a single discussion, but we really do welcome you, and we're glad you're here. And please don't feel free to contact us after the talk if more questions or things come up afterwards. So, getting into the problem, sarcomas are stubborn, and the NCCN breaks them down into 2 main classifications. And what I mean by that is they're difficult to eradicate with radiation alone. And we'll talk a little bit about the history of that, both soft tissue and bone sarcomas. And really, it's a wide-ranging histology. So the WHO releases classification guidelines for these types of tumors. And what we're learning with more advanced pathology and genetic sequencing, we're finding that these are really diverse genetic and biologic tumors. So to just break it up into 2 of the classic stratifications is really an oversimplification. And really the talk is focusing on non-small round blue cell tumors. They're sort of a separate category, and they can be very chemoradiosensitive. So the problem, as we're all familiar with this, they can be stubborn. And that's what we see in our practice as well. And this evidence comes back from dating back to a study that was done in 1985. So this is from MGH, some of the leaders in the radiation oncology field. And what this is showing is that this is a survival curve showing the number of patients surviving at time 0, 100%. And this is measured in years in the x-axis. And this is using lower radiation doses. Only about 9 patients in the entire study received doses greater than 65 gray, cobalt gray equivalent, which we would consider sort of a moderate or lower dose by today's standards. And so we can see that with lower doses of radiation therapy, historically, patients with certain type of sarcomas of the spine, pelvis, and skull base have not done well with the previous available forms of treatment. So we see that clinically. We also see that in vitro as well. So this is an in vitro study looking at different X-rays in looking at cell lines with surviving fraction and dose on the x-axis. So it's looking at X-rays in blue, and then 2 types of a particle therapy, carbon ions, in the red and the green. And what it's showing is that with higher radiation doses, a lower percentage of cells are surviving, and additionally more potent forms of radiation. And at the end of the talk, we're going to talk a little bit about some of the developing research within proton therapy, how there's variable RBE and ways to potentially access some of those higher energy and higher biological equivalent doses of radiation therapy for further biologic potentiation of treatment efficacy. And so this forms the basis of the technical challenge. So this is sort of more for the radiation oncologist. It samples from NCCN and NRG guidelines. And essentially what to take out from this is that the dose needed delivered that we know from studying patients in order to control a tumor tends to be higher for a lot of bone and soft tissue sarcomas than the organs at risk surrounding it. So it creates this paradox where we need to give more radiation dose than the sensitive neurovascular structures that are immediately adjacent. So therefore, it creates issues where we need to make judgment calls and use all of the available surgical and radiation techniques in order to spare those normal tissues in order to improve patient outcomes. So the main thing to take away from this for those people in other specialties is that we need more radiation than typically the surrounding structures can tolerate. And so we have sophisticated ways of dealing with those challenges, but certainly it's something that we face on a daily basis in our clinics. And so what this sets us up for is what makes proton therapy different is that it's an advanced form of radiation therapy that allows for dose intensification, that dosimetric improvements have allowed for delivery next to adjacent tissues, sensitive neurovascular tissues. And then thirdly, we're going to talk about the potential for biologic equivalent dose pating for even widening that therapeutic ratio. So beyond the dosimetric advantages, there's some interesting things coming in the pipeline that may be able to further potentiate that. So I think we're up for the next poll. And so this is going to test to see how many radiation oncologists or people who've been to a proton talk have been before. So most proton talks include what topic? This is kind of a trick question. All right, we'll give it 3, 2, 1. All right, so end poll. So I think the winner of this is a dose distribution. And you're exactly correct. So we will be looking at some dose distributions. Bragg peak, we'll be looking at that on the next slide. And then CSI, I thought about adding a CSI field of a medulloblastoma just to complete it, but it was a little off topic. So obviously, you'll have to refer back to one of my colleague, Dr. Indelicado's prior talks. So obviously, getting back into getting into the next thing, the Bragg peak, and this is, defined by the Bragg curve. So William Bragg was the person who initially developed this curve. And what this form of radiation does is there's a specific dose distribution that we see. So this is depth in the body, and this is the amount of radiation. And so you have this phenomenon where you have a low entry dose, all of the radiation, the significant proportion of the radiation is actually delivered in your target, which is often the tumor, and then you have no exit dose. And so this is showing what that looks like in a patient. So this is what a typical X-ray would look like. So you actually have higher amounts of radiation delivered in the entry tissues, and you have lower doses than your entry dose within the tumor. And then you also have an exit dose. With proton therapy, because you're concentrating the radiation within the tumor, you actually get a differential, and the integral between that, the area under the curve, is the dose reduction from proton radiation therapy. And in any talk you go to, that'll probably be one of the first slides that's shown. So that's the sort of the physical reason. And the reason is protons are a particle. So this is one of the CME questions. It is not on the electromagnetic spectrum. It is not a photon. And because of that, we can actually stop where it's deposited in tissues. And that's the whole physical basis for why protons work. So the first question you may have is where the center is located, what is the team involved, and sort of what's the technical delivery like. So this is the most recent update from NAPT. So this website's a really good resource if you're an oncologist or another person who's interested in referring a patient for proton therapy or interested in the centers located. So there's currently 37 in the US. We do have some international colleagues on the line. So there are other sources for international sites, but this is purely based in the US. It's been FDA cleared since 1988 and over 200,000 patients treated worldwide to date. And NAPT is a really good website for looking up more information if interested. And this is a screenshot of a lot of the people involved. And obviously we can't fit everybody involved. If you notice, I put the physicists front and center on this talk in terms of the team involved. And really it's a very advanced technical operation that requires a lot of people with advanced training. And we have 9 PhD physicists that we work with. There's a whole support staff with dosimetry, therapists that are actually treating the patients, as well as the physician. So the role of the physician is to help direct and oversee the overall operation. But really we work with, it's an extremely technical field, and we're working with a lot of important members of a whole medical team in order to deliver care for these patients. And this is very similar at any center in the country that's treating with proton therapy. In terms of the 2 different types of proton therapy available, there's double scattered and there's pencil beam. Double scatter is the original technology that's used. And what it's doing is you're actually using a brass aperture and a lucite compensator in order to shape the beam around the target. Newer forms of proton therapy, which are now widely available in the latest technology and machines, what it does is it actually uses magnets to shape the beam. And I think it's better to look at a video of this. This is from IBA's website. This is showing a typical gantry. So this is the gantry room. This is it showing treating a patient. This is the gantry head. There's a cone beam CT that takes pictures and verification beforehand. The cyclotron has 230 MeV proton energy, 360 degrees of treatment access. This is it painting layer by layer, almost like a 3D printer, painting each layer of where the radiation is supposed to go. The couch has 6 degrees of freedom with a robotic positioner, and then 3D cone beam CT verification for positioning. This is really important because we have it's very sophisticated ways of delivering the radiation. So being able to verify the patient's in the right position is of most importance. And that's what you see here. So this is actually what the machine looks like. So this is the gantry on the left. It's actually this machine from Proteus One and IBA is made in Belgium. The gantry weighs 100 tons, so we're only seeing a very small part of the treatment room. The cyclotron, which is here, which actually generates the protons, which is guided by magnets into the treatment room, is 50 tons. In terms of how it was built, and it actually took 5 days to build a crane in order to lift it in the building. So obviously a very sophisticated and technical operation in order to actually deliver this and make this available for patients. Okay, so what evidence is there to support proton therapy in these patients? Is it brand new? What is the evidence for protons, and what is the evidence for sarcomas? Robert Wilson is considered the father of proton therapy. And, one thing is he worked in the Manhattan Project. He was key in the development of Fermilab. And actually, he's the first one that reported back in 1946. So proton therapy is not something new. It's something that's been thought of as a while. It's just really taken the technical developments in computer science, computer engineering, in physics in order to actually make that deliverable for patients. So for the radiation oncologists and some of the other oncologists who've had experience in other forms of radiation, we'll just take a second to see where we've come from to really go into where we are now. So this is a cobalt machine, which was actually a radioactive, it treats patients with radioactive decay. So the source has to be replaced every 5 years or so. And it was a very slow form of delivery and it very effective, but we weren't able to really shape the beam and to, conform it to the shape of the tumor. And then obviously the progression with linear accelerators, which are extremely widely available and very effective form of radiation. And then also proton radiation therapy, which is another form of therapy, which the goal is to reduce the number of side effects. And so I'm going to get into this. And does anybody, this is our next question. We'll see how many sports fans we have here. Does anybody know who this is? And I'll get into why we have this person here. And I apologize, the top for the Alabama fans, the Saban is spelled incorrectly, but I'll give it 5 more seconds. Okay, so you all are pretty good. So it's Coach K. And so I have this picture of Coach K who doesn't look the happiest. But the reason why I put it here is because one of the things that I really admired, in reading about Coach K is that his wife, would sort of catch him yelling at himself in the mirror. And he really was his own best critic. And I think radiation oncologists really have that introspection as well. And sort of it gets us to where we're going with the field and what we've done in the past. So this is a picture of how radiation oncology used to be delivered. And as I said, it was a very highly effective treatment. But this is showing on a 2D film in a clinical setup of a low anterior neck. So on these films, the radiation oncologist would delineate where the radiation is going. It would be a very simple technique. And this is what it would look like. So the radiation fields would be very large, and we wouldn't have much ability to spare some of the critical tissues. So this is a CT scan, and this is called an isodose dose distribution. And the area in red is getting the full radiation dose. And you can see most of the normal tissues within the nasopharynx, the oropharynx, salivary glands, oral cavity, and larynx were receiving full radiation doses. And it, at that time, it was what we, the best of our ability to do. However, obviously, this has side effects and isn't necessary, as we know now, for eradication for some types of tumors. And from the head and neck world, there's been a lot of landmark studies. This is the Passport study, which was actually a randomized study. The red is the conventional radiation techniques, and then the blue is the with IMRT, and you can see significant reductions in xerostomia, which is dry mouth, from using more sophisticated and conformal techniques for delivery. And this is what it would look like. So this is what a typical IMRT plan would look like. This is a patient who was actually treated on a de-intensification trial for an HPV positive head and neck cancer. And this is showing the 60 gray X-ray plan, and you can see the low dose bath to some of the surrounding oral cavity and salivary structures. So even with, in some sites with dose reduction, we do see reductions in to normal tissues and surrounding structures. This is the excess dose deposition, and even in other areas of radiation oncologists. And I bring this in the skull-based world because oftentimes when you're treating cervical spine tumors or areas of the skull base, this can be an issue. And certainly in other fields of proton therapy and radiation, we've made large advancements. And there's more evidence. This is also to show you the NAPT website. There's clinical research. The website's here for your reference later to show the evidence that is compounding for reduction, xerostomia, feeding tubes, and whatnot for tumors of the head and neck. So one other area that we looked at, and I had a personal, interest in, is Hodgkin's lymphoma. Doing some outcomes research study during my training, and this is what it looked like in the charts. This is from patients. You can see August 9th of 1965. So this used to be a universally fatal disease, and radiation oncology truly altered the course of this disease and made it curable in a large percentage of patients. And this is showing what the field looked like. So it was done by hand calculations, and you can see that they block the heart. They used to treat the entire heart. So if you're an oncologist who's seen patients with long-term side effects of radiation, it's weighing into, some factors, from prior experience, radiation oncology has come a long way, and certainly fields like this are nowhere near, what we're technical and are indicated currently. And so this is treating, an entire mantle field with a subtonal irradiation, but, the entire mediastinum, heart, abdominal, and pelvic structures were receiving clinical radiation doses with these techniques. And certainly when we've done outcome studies, we've looked at it, a high percentage of patients have developed second cancers or cardiotoxicity from the low dose effects of long-term irradiation. So we've certainly learned from the past, and doing our best to reduce those side effects for patients in the future. So we're at our next polling question, and this has to do with the history of Dr. Thomas Hodgkin. And so, does anybody know where Dr. Hodgkin's resting place is? This is kind of a minutia question here. And I know we have some folks from the UK, so. All right, we'll give it 2, 3, 4, 5. Okay, we'll end it now. So although he worked at Guy's Hospital in London, so he actually was on a mission trip in Jaffa at the time. So his burial place is actually in Jaffa, just a city near Tel Aviv. And so it's this is his tombstone. And the really interesting, not a lot of people know, it's actually in a person's backyard. So this cemetery is actually down this alleyway. It's extremely hard to find. Not many people know about it. Only the people who are interested in the history of Thomas Hodgkin. It's actually in this person's backyard. So if you ever have the chance, you're in the area, it's a little known secret that you can check out, and you'll know as well. So, getting back to the second cancer risk, this is from a study from the Stanford group that looked at a large database study, and looking at this plot in the combined pool analysis, looking for all sites, they actually saw that this risk of second cancers following patients that were treated with proton therapy was lower than IMRT. And the authors, who are at an institution that does not deliver proton therapy, actually concluded that the risk of secondary cancer was lower. So, obviously we're using these techniques in order to hopefully better reduce long-term toxicities for the patients that we treat. So now we've talked about sort of the history of radiation oncology, where we came from, and sort of where the field is moving. Well, what is the role for dose escalation? As we discussed prior, doses less than 70 Gray have been suboptimal for the treatment of certain types of bone sarcomas. And so this is from a review study where we looked at several institutions around the world that were treating with proton radiation therapy, which show with doses of 70 or greater quite more favorable control outcomes than the previous historic literature with conventional treatment with lower treatment doses, lower than 70 Gray. And this is something that was seen in another database study with over 1,400 patients. About half were chordoma patients, half were chondrosarcomas, where the black line is protons. You can see that the number of patients is small. So, I think that always take that into consideration interpreting these graphs. But certainly this group down in Tampa, which is another site that does not have protons. So, obviously they're not biased, and you can say that they're completely impartial to the results of the study. They showed that both proton therapy and 70 Gray, or dose escalation, was associated with improved outcomes for patients with chordoma and chondrosarcoma. So the patients actually lived longer. And that is what the authors concluded. And and actually, I think Dr. Palm is actually rotating at the UF Proton Center right now as well. So we've had the chance to interact with him. And then lastly, this is another update from, a study that we looked at, looking at the NCDB database specifically for chordomas and chondrosarcomas of the skull base, and similar findings on some of the building on the work that the previous group did. Is interesting that both facility volumes, so people that are doing it more often, specifically more than 10 cases over a 10-year period, so it's really only one a year, and those typically tended to be academic centers, and most often those patients were getting adjuvant radiation therapy, and the most common type of radiation therapy at those centers was proton radiation. Now for another evidence for dose escalation. This is actually from one of the small round blue cell tumors, which I mentioned is sort of a lower dose. This is from pediatric literature looking at St. Jude's Research Hospital, a phase 2 study where they were both shrinking the volume, the size of the radiation field, as well as giving higher doses of radiation for large tumors. So historically, we know that gross disease greater than 8 centimeters in these patients, they've done poorly they've done more poorly than patients with smaller tumors. And in this study, what it's demonstrating is that those patients, even with greater than 8 cm that were treated to 64.8, which is considered escalated as compared to the, most people's standard of 55.8, they actually had no local failures within that escalated group. So that's remarkably impressive, and they were able to do that safely. Most of those patients were treated with protons as well. So now getting into the specific sites, so starting with the skull base. So obviously the most common surgery that we deal with, an endoscopic resection. This is how neurosurgeons often, or at least I'm told, approach the skull base, whether it's an anterior, anterolateral, posterolateral approach, really defines how they geometrically approach the surgery to remove the tumor. And so the keys to success. So really, as a radiation oncologist, the best way to reduce to dose escalate is really to avoid a compromising issue. And I'll get into how we do that, to visualize the target, and then obviously use newer advanced radiation techniques to precisely target the area of interest. So the first thing is geometric optimization, and this is absolutely critical. There is no dose escalation without this. And I know this is sort of a lesson in history. I don't know. I know some of you. I know some. It might be dating myself, but this is what I think of when I think of geometric optimization. I think back to my younger days playing this game. But this is really the critical issue. And so this is a patient with a locally advanced chordoma, craniocervical junction of the chordoma, spanning the entire clivus and invading into the sphenoethmoidal sinuses, as well as involving the anterior cranial fossa. So the point is, you stop. This tumor is completely involving both optic nerves. It's abutting the brainstem. It's invading into the cavernous sinus bilaterally, and this is what we see on this axial and coronal MRI. So the point is that there is no dose escalation in the setting because the tumor is directly involving those adjacent sites. So this is showing an example of another skull-based chordoma. This is preoperative imaging. This is a T2 weighted MRI. It's a certain type of sequence of imaging where the tumor appears bright. So this is the tumor outlined here with the arrow. And this is showing that with the surgical resection, you're actually able to remove part of the tumor and therefore able to fully dose escalate and achieve 70 plus gray to the brainstem. Typically, we'll treat up to the surface of the brainstem to 60, 70 max. And, we have a very high safety profile with actually no major brainstem complications using that approach in the patients we've treated. The next thing is really visualizing the target. So this is an MRI, a T2, again, another T2 postoperative MRI, where you can see there's just a little faint area right next to the right M1 segment of the vertebral artery. And so really visualizing your target, when we got a high resolution T2 space MRI, you can clearly see that that's tumor. So, you're going to be limited in terms of dose escalating when it's directly abutting. So again, making sure to adequately image it in order to best discuss with your surgical team in order to plan the postoperative radiation therapy. So really, putting the effort up front in order to avoid any type of compromising issue. So the last thing is, so here's the Tom Brady, and then obviously is the it factor. And so this is Justin and Kelly as well. And they all have it. So for the sports references and the American Idol as well. And the reason why I show this is that, obviously, in the surgical literature, usually this is very sophisticated techniques and surgeries, and it takes about 5 to 7 years for some of the surgical teams working together to really approach the maximal cohesion that we see. And so this is an example of a chordoma on a T2 MRI invading the brainstem with mass effect that's pre-op and post-operative, and it's sort of an amazing resection to see, and we'd be able to adequately treat this patient without to dose escalate the post-op resection area. So obviously this is sort of an it factor that it's something that you really build up over time with working with the same cohesive unit. And then the last thing, sort of adding available technology. So this is showing a dose distribution of a plan. This is with protons of a young patient with the petroclival chondrosarcoma. So obviously this is the color watch dose distribution. The total dose is 70.2 gray. And it's showing how with protons we can treat this adequately dose the target without compromising target coverage, mitigate dose to the brainstem, avoid that low dose to the bath, as well as avoid the optic apparatus and contralateral temporal lobe. This is with an X-ray comparison showing how even using non-coplanar techniques in order to optimize, coverage parameters that, still, you're going to be dosing the parotid, the contralateral temporal lobe, and in this young woman, avoiding some of those long-term complications down the road. And then again, another tumor with actually a really good prognosis with radiation, another orbital soft tissue sarcoma, orbital solitary fibrous tumor. This is showing a non-coplanar technique in order to better spare the retina in this patient using the X-ray plan. So you can see low dose to the brain, pituitary glands, so hypothalamic pituitary axis, nasopharynx, and all these structures, albeit low dose, is certainly not needed for control of the tumor, and certainly having neuroendocrine dysfunction or optic or retinal issues related to the retina dose is something that could contribute to this person's quality of life down the road. So those are some of the issues that come up in the skull base. So now moving on to the spine and pelvis. So before we get started, so we'll ask our next poll question. And so this is sort of for our neurosurgeons. So spinal stabilization for patients with chordoma have what treatment outcome compared to those without it? So if you have spinal stabilization, is it a good thing or is it a bad thing? Okay, so we'll end this here. So we'll end the poll here. So this is really interesting. So I'm glad we asked this. So the most common answer was a better outcome. And so the correct answer, and this is an important question for CME purposes, it's actually a worse outcome. So at least from small single institutional studies, this is from our colleagues in Switzerland. And what they saw is patients with surgical stabilization, present had worse local control and worse disease control following pencil beam proton at their center. And there's a lot of contributing factors, extent of disease. But, one of the factors, and I want to get to in this next slide, is, hardware artifact issues. And I think this is something that, as colleagues, we can work together on and sort of, a really good area for collaboration. So this is again showing an MRI in a patient with titanium hardware stabilization with a cervical spine poorly differentiated chordoma. And, what this is showing is sort of these black areas, and this is the spinal cord. Again, getting to the visualization, there is no way any radiation oncologist can safely dose escalate in somebody with this postoperative imaging. And this is even with, artifact reduction techniques, without being able to see the spinal cord. And this is a CT scan. The spinal cord's in here. There's no way for, for us to safely see it in these situations. So without proper visualization of spinal cord, without a myelogram or other imaging, there'd be no way for us to safely deliver dose-escalated protons to this patient. So I equivalent it to sort of flying blind, and for today's modern age, not only is it flying blind, but if you look very closely in his hand, you can see something, and the person is texting while flying blind. So it's really just a situation where you want to make sure that you're able to visualize the critical OIRs. And so luckily for this situation, one of our physicists is trained in sort of advanced imaging techniques with a 0.23 Tesla that we have in-house, and we're able to simulate the patient. You can see this area is the spinal cord, so you can clearly see the spinal cord delineated in the CSF that you would not otherwise to be seen in the outside diagnostic imaging or in the planning scan. So it's something that it's just really something that you need to be aware of in patients that may have hardware, because we know that the outcomes are worse. And I think some of it may be to do with other related factors, but some of it could also be contributed, proper visualization of the target. And this is something interesting. If you do have the option to talk with your neurosurgeon teams, or you are a neurosurgeon, obviously this is a new technology that, we're learning more about. And I'll say it once, carbon fiber reinforced polyether ketone, obviously for obvious reasons known as CFR peak is the short name, which most people say. But, this is a patient with significant hardware stabilization. And with these techniques, you can see how it's not causing metal artifact. And even on the CT scan, you can clearly make out the spinal cord. So it's something that where imaging is important, they're going to need radiation. If you do have the option of discussing with your neurosurgical colleague and it's available, then it's something to consider for those patients. And additionally, it also allows us to use a higher percentage of protons in order for the treatment plan. So I'll show some images of a C-spine and the T-spine chordoma that were treated. And actually, we typically use about 50% of the plan. We use photons in patients with titanium hardware that are overlapping with high-risk target structures. And the reason is this is actually a study that was done, a phantom study that was done in Switzerland. And what they did is they looked at a reference scan titanium CFR peak hardware. And the reason is historically, there can be anywhere from 10 to 20% heterogeneity and inhomogeneity within the radiation plans and uncertainties that without using one of those carbon fiber, hardware surgical stabilization can contribute to uncertainties within the plan. So because of that, we actually use photons for a small proportion in order to mitigate that difference. And by using the CFR peak, this study showed, and you can see this, the blue lines are 5%, the red is 20% differences in heterogeneity. With the CFR peak, it's much less, it's much more reduced. So typically we can even reduce the amount of X-ray component that we give to these patients. So it has clinical impacts as well as imaging. And so this is a patient that was treated with the combined techniques. So the boost of the proton plan is on top and then the X-ray is on bottom. So obviously we know that from treating other sites, sparing dose to the heart, obviously the spinal cord, lungs is something that has been associated, obviously higher dose to the heart. We know from our colleagues in the lung cancer world has been so associated with poorer outcomes in those patients. And then lastly, for the C-spine chordoma, which I showed earlier with the titanium hardware stabilization, this patient actually had poorly differentiated chordoma. Some of the interesting things, I know our medical oncologist, the loss of I&I, a lot of these patients, are treated with adjuvant chemotherapy, either induction or potentially if they have loss of I&I. There's some new medicines and targeted agents that really target that, the EZH2 receptor. I think it's called tazemetostat, and some of these agents, are coming onto the market. And this patient's actually currently on that, and doing well. And obviously we can see this patient actually was treated with this X-ray plan because of the hardware for the first half of radiation plan. You can see with the boost, obviously, reducing off of the cord and some of the salivary structures, very similar to the head and neck plan that we saw earlier, avoiding the oral cavity. She's actually doing really well. We've not been any disease progression, and quality of life is really very high at this point. And then obviously for pelvic chordomas, the big issue with these patients is the extent of resection of the sacrum. So the more of the sacrum and the bilateral sacral nerves that you need to remove, really above the level of S2, puts patients at risk for urinary and bladder incontinence, which is a problem going to the bathroom, potentially weakness in their lower extremities. So this is a patient treated with adjuvant proton radiation therapy to 7380, again, showing, low dose reduction to some of the surrounding tissues. One of the key features here is obviously, the role of primary protons versus, upfront surgical management. It's an active research question, and there's current clinical trials going on, especially for patients where it would be a morbid resection. And then the other thing is one consideration that radiation oncologists, and this next slide is, if you do have gross disease, oftentimes depending on the myocutaneous flap placement that that's placed at the time of surgery, sometimes spacers or other spacing device, very similar to in the skull base, can help you fully dose the target safely by actually putting a physical distance between both the target and some of the adjacent bowels. So this is the rectum located right here, but you can see obviously in a woman, completely sparing the ovaries, and obviously, which is, very important in some of the pediatric patients and young patients we treat. And now, so areas of active research. So I showed a lot of sort of dose distributions, the difference between X-rays and protons. This is something that I find really interesting, and one of the areas of active research, and the radiobiologic potential for widening the therapeutic ratio. And so there's a lot of interest in, there's a lot of interest in moving not just beyond the dosimetric advantage or some of the biologic. And, one of the ones that's really preclinical that we'll first talk about is FLASH. And this is actually ultra high doses of radiation. This is a picture from Varian, and it's actually orders of magnitude faster than current radiation techniques, and it's delivered with Varian's single gantry proton machine. And it's called the flash effect because it's so quick in histology and in vitro work. What it does is it actually spares the normal tissue and just damages the cancer cells. And this was initially looked at in the 1960s and 70s. It was abandoned because the worry would be is it would spare tumor cells, which is the goal of treatment to eradicate the malignancy. But it really is making a revival, and there is some early phase 1 studies that are currently underway and looking at this. So it'll be really interesting to see what comes of this new advancement. And this is another one that I think is a little bit closer to the clinic that I just find really interesting. And it's one of the things about protons is there may be a way to modulate actually the biologic activity of the protons based on what you're treating. So we know that with X-rays, the way it works is it causes DNA damage. And I liken it to sort of like, bowling balls, and, the DNA is the target, is the pins. If the heavier the bowling ball, the more damage you're going to do to the pins. So there are heavy forms of particle therapy, and they're always sort of that heavier particle. But with protons, there's actually a lot of evidence that it may be variable. So actually at the distal end and in deeper, at the depth of the tumor and tissue, we find that at that distal peak, the protons may actually be more biologic effective. So you have this variable RBE, and you make it the situation where you can actually escalate the biologic efficacy of the protons within the tumor and actually have lower forms of those and avoid the distal beams with near critical structure that's immediately surrounding it. So it's something, because there's that, theoretically, there is that variable RBE. It's something that currently the vendors are, putting into the software system, and something that's a current active research question, and maybe something that we see relatively soon. And this is a study that was done out of MD Anderson, looking at that factor. So on the top, they looked at, this was published within the last 6 months, looking at different ways to optimize within the target. So this is a target of a patient. This is using standard 1.1 RBE, so a stable RBE, and this is using a variable LET. And what they found is by using different optimization algorithms, specifically this distal end avoidance, you can actually get a very similar pattern to some of the LET optimized beam patterns. And what's really interesting is you can see this is the target in green. The red areas, the higher LET particles within the target, and you actually have a cool interface at the brainstem where you'd want it, which you don't see in the variable RBA methods, which are optimized by dose and other factors. So, something that I think is coming soon in the clinic, and something that may be an additional way to dose escalate and get more biologic active particles within the target itself. Another way looking at that, improving actually some of the high dose and low dose conformality. So the group at Beaumont is applying for a patent for spot scanning or reapplied to the FDA for clinical use spot scanning proton arc. So these are some dosimetry overviews. And again, it's actually removing some of the moderate and low doses of radiation and using actually arc with proton therapy and actually further improving the high dose conformality as well. So some interesting things from the technical basis. And additionally, this is also some group, the Beaumont group has published on this, but some other groups as well. Using those ARC techniques, it's also a possibility. You could use it with, standard 3 or 4 field IMPT, but also a way, this is looking at clonogenic assays, a way to get higher cell kills. You see with the IMPT versus the ARC, you actually are killing more cells by using the ARC, optimizing the distal Bragg peak within your target. And then, so lastly, this is, I know that we covered a lot of information, and like I said, this talk is by no means just the only talk within dose escalation within these areas. It's a wide ranging histologies with a lot of nuanced differences, but I hope I've discussed some interesting topics that are relatable to a lot of different fields and some of the, concepts that we're sort of facing clinical application within treatment for our patients. And this is some of the research efforts and that have been done in clinical research within the areas, published articles. And then lastly, I know that it's about approaching 5 o'clock on a Tuesday, and I appreciate you all joining us today. And the Zoom fatigue syndrome breakout session will be starting right after this. So thank you for your time today. And obviously, if there's any questions, we'd be happy to go over those.
Thank you so much, Dr. Holtzman. I can definitely tell that you're passionate about what you do. So we appreciate you sharing your knowledge with us today. We're going to open it up for questions. We have some questions already. One is in the chat, and it says, would you say radiation oncology's biggest focus is efficient delivery? Meaning, are there other therapies that are more promising than particle-based therapy, or is the focus centered on developing better delivery techniques?
Yeah, so that's that's sort of a multifaceted question. I think the field is multi-pronged. So obviously the focus today is things that we can optimize within protons, but there's a whole world of there's a special edition IJPT. The group from MD Anderson reviewed some of the biologic advances that are being used with protons in the head and neck world. And so that article, when it comes out, is a really good resource. So there are other avenues that are being done for the purpose of today's talk. Obviously we're focusing on protons and the things that we've done. But certainly, that's been a major focus of our field. And but there certainly are things that people are looking at. But certainly, obviously we have to limit the discussion. Too much fun things to talk about. We have to limit it, somewhere.
Thank you. I had another question that was sent in to me from a Mohs surgeon, and they occasionally have patients with perineural invasion, at times extending within the cranial bony foraminae.
Yes.
Proton therapy effective for control and cure?
Yeah, so actually there's a review article that Dr. Mendenhall And I published, I say within the last 6 months to a year. And then my colleague, Dr. Bryant, Dr. Curtis Bryant, who works with us, is actually first author. We're publishing our, experience of treating about 30 patients with proton therapy. And, I think it is something, and the reason is that, obviously with these patients, it's a very serious thing, and really local control is sort of what's defining how do these patients do. And, there is a lot of morbidity associated, especially patients with V1, in the cavernous sinus that's immediately, and that's where I get back when it's immediately overlaying some of those, optic apparatus, and certainly being able to limit the moderate dose to some of the adjacent optic nerve and temporal lobe. Certainly it's something that we've been able to do in our patients. And so we routinely use protons for those patients. And typically we use pencil beam for those patients to have the higher dose conformality. So we have both techniques available. So certainly we see in our practice, I think it'll be the only publication on the topic. And actually it's going to be in that head and neck IJPT edition, which should be out sometime within the next several months. So thank you for asking that.
Yeah, great question. And then let's see, we've got another question. How is LET optimization different from DEA optimization?
Yeah, so that's that's a very complicated technical talk. If you get their email, I'd be happy to sort of send the article and send you the link to it. But it's a very sophisticated thing that they go into, and I'm happy to sort of I appreciate you asking that question, and I can send you the article offline to go in further depth.
Okay, thank you. All right, let's see. Any more questions here? All right, a lot of thank yous, Dr. Holtzman. We really do appreciate your time. We really appreciate everyone who joined us today. And if you have any other questions, reach out to me. My email's all over this. Just reach out. We'll get some answers for you. And then there's a link to one of the CME survey in the chat box as well.
All right, and then I just put my email in there as well. Feel free to reach out at any time. We really appreciate you having here, and I hope you all enjoyed the talk as much as we all did providing it. Thank you.
Thank you, Dr. Holtzman. Thank you, everyone.